Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures. This introduction to adult cardiac arrest resuscitation emphasizes the fundamental concepts before detailing management and interventions. Cardiac arrest is characterized by three key indicators: unconsciousness, a lack of breathing, and the absence of a pulse. This condition signifies a complete lack of circulation signs and is recognized as a significant public health issue due to the high mortality rates observed worldwide. Despite the advancements made in resuscitation science over the years, the outcomes for patients experiencing cardiac arrest remain poor. To improve patient outcomes, the chain of survival framework is an essential tool that outlines the critical steps necessary for successful resuscitation. This framework makes a distinction between the chains for out-of-hospital and in-hospital cardiac arrest scenarios. The key phases of this framework begin with the early recognition of cardiac arrest and the activation of emergency help in both settings. Recognizing a cardiac arrest and summoning assistance are crucial first steps that need to be taken immediately. Following the activation of emergency help, the next step is to perform high-quality cardiopulmonary resuscitation to restore blood flow to the heart and brain. This involves delivering effective chest compressions that are vital for maintaining circulation during cardiac arrest. Furthermore, defibrillation plays a critical role in the survival of patients with shockable heart rhythms, such as ventricular fibrillation or pulseless ventricular tachycardia. Prompt defibrillation can significantly enhance the likelihood of favorable outcomes. After initial resuscitation efforts, the advanced resuscitation phase builds upon basic life support by integrating advanced interventions. These interventions may include the administration of medications, the use of advanced airway management techniques, and the identification and treatment of reversible causes of cardiac arrest. Post-cardiac arrest care is focused on addressing the systemic effects of ischemia and reperfusion. It involves identifying the underlying causes of the cardiac arrest and optimizing organ function to facilitate recovery. Additionally, recovery acknowledges and addresses the long-term physical, cognitive, emotional, and social needs of survivors beyond their discharge from the hospital. By the end of this section, learners will be able to define adult cardiac arrest and describe its epidemiological significance and typical outcomes. They will explain the concept of the chain of survival, differentiating between the out-of-hospital and in-hospital chains. Additionally, learners will identify the key components of basic life support, which include recognition, activation, high-quality cardiopulmonary resuscitation standards, and early defibrillation. Furthermore, this section will cover the principles of advanced life support. This includes the role of advanced airway management, vascular access, and pharmacotherapy during cardiac arrest. It is essential to discuss the purpose and the evidence supporting the use of epinephrine in adult cardiac arrest resuscitation. This includes its application for both shockable and non-shockable rhythms. Learners will also recognize common primary cardiac and non-cardiac etiologies of adult cardiac arrest, paying special attention to reversible causes often summarized by mnemonics such as the H's and T's. They will summarize the critical aspects of post-cardiac arrest care, including the concept of post-cardiac arrest syndrome and key interventions like targeted temperature management and emergent angiography. In addition, this section will outline specific considerations and interventions for managing cardiac arrest in unique scenarios such as anaphylaxis, post-cardiac surgery, or pulmonary embolism. It will describe the role and limitations of various medications used during cardiac arrest, including antiarrhythmics and agents for specific etiologies like hyperkalemia or toxic overdose. Lastly, learners will explain the evolving importance of the recovery phase in the chain of survival. It is crucial to recognize the long-term needs of cardiac arrest survivors. Cardiac arrest is a critical event characterized by the combination of unconsciousness, apnea, and pulselessness. This medical emergency represents a significant public health issue, as it is associated with high mortality rates. Understanding the epidemiology of cardiac arrest is essential for informing public health initiatives, emergency response planning, and clinical strategies. In the United States, it is estimated that more than 340,000 out-of-hospital cardiac arrests occur annually, with approximately 180,000 of these cases being treated by emergency medical services. Globally, hundreds of thousands of individuals experience cardiac arrest each year. In the United States alone, it is estimated that over 600,000 cardiac arrests are performed annually. The majority of out-of-hospital cardiac arrests treated by emergency medical services occur at home, accounting for 70% of cases. Furthermore, in-hospital cardiac arrests also affect a substantial number of patients each year, with approximately 2,000 cases reported in Denmark and 300,000 in the United States. Witness status plays a critical role in the outcome of cardiac arrest cases. A significant proportion of out-of-hospital cardiac arrests are unwitnessed, with around 50% of these cases lacking any witnesses. Additionally, the rates of bystander cardiopulmonary resuscitation are low, averaging approximately 40%. The initial rhythm observed in patients who receive treatment from emergency medical services shows that the proportion of those presenting with an initial shockable rhythm, such as ventricular fibrillation or pulseless ventricular tachycardia, has declined over time to about 18%. This rhythm often indicates a primary cardiac origin, such as coronary artery disease, which is common among patients experiencing out-of-hospital cardiac arrest. However, there are also common cardiac arrests that do not have a primary cardiac origin, including those resulting from respiratory failure, toxic ingestion, pulmonary embolism, or drowning. These cases often occur more frequently in the in-hospital setting. Despite advancements in resuscitation science, overall outcomes after cardiac arrest remain poor. Key outcome measures frequently reported in the literature include returning to spontaneous circulation, surviving to hospital admission, surviving to hospital discharge, and achieving a favorable neurological outcome. Overall survival rates are concerning globally. Fewer than 1 in 10 people survive if the cardiac arrest occurs outside of a hospital. In contrast, roughly 1 in 5 individuals survives if the arrest takes place inside a hospital. In the year 2017, only about 25% of patients who experienced an in-hospital cardiac arrest survived to hospital discharge in the United States. More recent data from the year 2020 indicates that overall survival to hospital discharge for adults was 9% for out-of-hospital cardiac arrest and 23% for in-hospital cardiac arrest. This substantial difference in outcomes between the two settings likely results from reduced delays in initiating effective resuscitation within a hospital environment. In terms of neurological outcome, achieving return of spontaneous circulation is just the initial step. Neurological recovery represents a critical aspect of survivorship following a cardiac arrest. Post-cardiac arrest brain injury significantly contributes to death and disability. Studies evaluating the use of vasopressors note that while some of these medications may improve return of spontaneous circulation or survival to admission, they do not consistently demonstrate improvement in survival with a good neurological outcome. Achieving survival with a favorable neurological outcome is a key endpoint in evaluating various interventions. The prevalence of severe disability or vegetative state among survivors of in-hospital cardiac arrest can range from 25% to 50%. Several factors influence outcomes in patients experiencing cardiac arrest. The initial rhythm of a patient plays a crucial role in their prognosis. Patients presenting with shockable rhythms, such as ventricular fibrillation or pulseless ventricular tachycardia, generally have a better prognosis compared to those with non-shockable rhythms like asystole or pulseless electrical activity. Despite this, survival rates remain low, even among patients who require adrenaline or intubation. Bystander cardiopulmonary resuscitation significantly improves survival rates. Lay rescuer CPR can increase the likelihood of survival by 2 to 3-fold. Furthermore, the timing of epinephrine administration is important. Some studies suggest that administering epinephrine earlier is associated with better survival outcomes for both shockable and non-shockable out-of-hospital cardiac arrest rhythms. On the other hand, delayed administration of epinephrine is linked to a decrease in the odds of survival to hospital discharge for non-shockable rhythms. Although later administration may increase the return of spontaneous circulation, it is inversely associated with survival to hospital discharge and favorable functional outcomes, indicating the presence of potential confounding factors. Epinephrine is a vasopressor that has been shown to enhance the rates of return of spontaneous circulation and survival to hospital discharge when compared to a placebo. However, its effect on achieving a favorable neurological outcome remains uncertain. Studies exploring the use of vasopressin alone or in combination with epinephrine in comparison to epinephrine alone have reported mixed results, and many of these studies have been underpowered to detect significant differences in long-term outcomes. Some research suggests that a combination of vasopressin, steroids, and epinephrine during and after in-hospital cardiac arrest is significantly associated with increased return of spontaneous circulation and potentially improved short-term outcomes. These outcomes include days free from renal or coagulation failure and improved management of mean arterial pressure. However, the impact of this combination therapy on survival to discharge and ventilator-free days has been non-significant in some meta-analyses. There remains uncertainty regarding the long-term survival benefits of this combination. Coronary angiography is often indicated in cases of cardiac arrest where coronary artery disease is suspected. It is recommended for patients with a suspected cardiac cause, particularly those exhibiting ST segment elevation on an electrocardiogram. For select patients without ST segment elevation but who have a high suspicion of coronary artery disease, early angiography may also be reasonable. The timing of these angiographic interventions is vital, as early procedures are associated with better short and long-term survival, especially in cases where shockable rhythms are present. Targeted temperature management is another critical factor. It has been shown to improve survival rates and functional outcomes in comatose survivors of cardiac arrest. For adults who do not follow commands after achieving return of spontaneous circulation, temperature control is advisable, maintaining a range between 32 degrees Celsius and 37.5 degrees Celsius. However, recent trials comparing a temperature of 33 degrees Celsius to normothermia or other temperature targets have not demonstrated significant differences in functional outcomes or mortality in specific patient populations, particularly those with cardiac out-of-hospital cardiac arrest and shockable rhythms. Managing post-rewarming hyperthermia is crucial, as it is associated with increased mortality. Mechanical circulatory support, including extracorporeal cardiopulmonary resuscitation, has gained importance following the return of spontaneous circulation to maintain organ perfusion, especially in refractory cases. While some studies indicate substantial benefits in select populations, such as those with refractory ventricular fibrillation, consistency in benefits across all forms of refractory arrest has not been established. Current literature lacks robust randomized trials to guide appropriate patient and device selection following the return of spontaneous circulation. The entire system of care, encompassing pre-hospital responses through to post-arrest management, significantly impacts patient outcomes. Consistent implementation of comprehensive, multidisciplinary protocols or care bundles can improve these outcomes. Finally, recovery and survivorship is now recognized as a distinct phase in the chain of survival. This phase acknowledges that recovery extends beyond hospital discharge, addressing physical, neurological, cognitive, emotional, and social challenges. Therefore, comprehensive discharge planning and survivorship strategies are recommended to address these long-term needs. First, it is important to understand the definition of cardiac arrest. This condition is characterized by a triad of symptoms: unconsciousness, apnea, and pulselessness. More formally, cardiac arrest is defined by the absence of signs of circulation. The management of cardiac arrest can be better understood through the concept of the chain of survival. This framework outlines the essential steps required to improve outcomes and underscores the significance of a timely and coordinated response. There are two distinct chains of survival, one for out-of-hospital cardiac arrest and another for in-hospital cardiac arrest. These two chains reflect the differences in the responses required in these different settings. In the out-of-hospital cardiac arrest chain, the first step is the activation of the emergency response. Following that, performing high-quality cardiopulmonary resuscitation is crucial. Afterward, defibrillation must be administered as soon as possible. Subsequent to defibrillation, advanced resuscitation efforts are necessary, followed by post-cardiac arrest care and recovery. Conversely, the in-hospital cardiac arrest chain begins with early recognition and prevention of cardiac events. This is followed by the activation of the emergency response and the provision of high-quality cardiopulmonary resuscitation. Defibrillation is also a critical step in this chain. Finally, care after cardiac arrest and recovery are emphasized. Within these chains of survival, basic life support and advanced life support represent distinct but integrated levels of care, contributing to the overall effectiveness of the response to cardiac arrest. Basic life support is essential in the early moments of cardiac arrest. This foundational approach emphasizes the importance of quick recognition of the situation, activating the emergency response, and administering critical interventions. Key interventions include delivering high-quality chest compressions and performing early defibrillation. The process begins by recognizing the signs of cardiac arrest, which may present as no breathing or only gasping, along with the absence of a palpable pulse. Once cardiac arrest is identified, it is crucial to activate the emergency response system. In cases of out-of-hospital cardiac arrest, this step enables the dispatcher to provide assistance for cardiopulmonary resuscitation. High-quality CPR is a fundamental and critical step in the process of resuscitation. Its primary aim is to restore adequate blood flow to vital organs, particularly the heart and brain, through effective chest compressions. To achieve high-quality CPR, certain benchmarks must be met. The compression rate should range from 100 to 120 compressions per minute. Each compression should reach a depth of 5 to 6 centimeters. Additionally, it is essential that the compression fraction is at least 80%, meaning more than 3/4 of the CPR should be active compressions. Full chest recoil must occur between each compression to allow the heart to refill effectively. A ventilation rate of 10 breaths per minute is also part of the guidelines. The overarching goal of high-quality CPR is to maintain continuous chest compressions with minimal interruptions. Two theories contribute to the understanding of how blood is propelled forward during these compressions: the cardiac pump theory and the thoracic pump theory. It is crucial to note that chest compressions represent the most vital component of CPR and must be initiated without delay. For adult patients, compressions should be performed in the center of the chest over the sternum, specifically at the level of the nipples. Rescuers are instructed to call for assistance, perform CPR with the intent to restore blood flow to the coronary and cerebral regions, and utilize an automated external defibrillator when necessary. Early defibrillation is crucial for survival in cases of cardiac arrest caused by ventricular fibrillation or pulseless ventricular tachycardia. This intervention is most effective when it is delivered as soon as possible after the onset of these conditions. Automated external defibrillators enable lay responders to provide early defibrillation. Research has demonstrated that the use of these devices can lead to high survival rates for individuals experiencing a cardiac arrest. In addition, it is essential to minimize pauses in chest compressions both before and after delivering a shock. Doing so maximizes the chances of successful defibrillation and enhances overall survival outcomes. Advanced life support, often referred to as ALS, builds upon basic life support by introducing more complex medical interventions. These interventions include advanced airway management, vascular access, and pharmacotherapy. In the context of advanced resuscitation, several critical interventions are employed. This encompasses pharmacotherapy, advanced airway techniques, and in some special circumstances, extracorporeal cardiopulmonary resuscitation. Advanced airway management is a key component of ALS. While initial airway management techniques may rely on basic methods such as bag mask ventilation, there are situations where advanced airways, like endotracheal tubes or supraglottic devices, may be necessary. It is important to recognize that the placement of advanced airways can potentially interrupt chest compressions. Research indicates that this interruption may not lead to improved patient outcomes compared to basic ventilation techniques. During the use of advanced airways, preventing hyperventilation is crucial, as excessive ventilation can negatively affect perfusion. To monitor the effectiveness of ventilation and the quality of cardiopulmonary resuscitation, end-tidal carbon dioxide levels should be closely monitored. Pharmacotherapy plays a vital role in supporting resuscitation efforts during advanced life support for cardiac arrest. Various medications are utilized in this process, with vasopressors being among the most critical. Drugs such as epinephrine are administered to enhance coronary and cerebral perfusion pressures during cardiac arrest. Epinephrine acts on alpha receptors, which increases both myocardial and cerebral blood flow, ultimately facilitating the return of spontaneous circulation. This medication is recommended for administration as soon as feasible when dealing with non-shockable rhythms and should be given after initial unsuccessful defibrillation attempts for shockable rhythms. It is important to note that the timing of epinephrine administration significantly impacts patient outcomes. Delays in administration can reduce survival rates for both types of rhythms. Although epinephrine has been shown to improve rates of return of spontaneous circulation, the evidence regarding its effects on survival to hospital discharge and neurological outcomes remains mixed and subject to debate. Another vasopressor of interest is vasopressin, which also promotes vasoconstriction and may increase coronary perfusion pressure. Various studies have investigated the effects of vasopressin, either used alone or in combination with epinephrine and steroids. However, research has not definitively demonstrated improved survival rates to hospital discharge or better neurological outcomes. Antiarrhythmic medications like amiodarone or lidocaine are considered for patients experiencing ventricular fibrillation or pulseless ventricular tachycardia that does not respond to defibrillation. Some evidence indicates that these agents can improve survival to hospital admission, and they may potentially enhance the chances of survival to discharge, particularly in certain subgroups, such as those involved in bystander-witnessed arrests. The routine use of sodium bicarbonate is not generally recommended, although it may be considered in specific situations, such as in cases of hyperkalemia or certain types of drug overdoses. Likewise, the routine administration of calcium during cardiac arrest is not advised. It is essential for advanced life support providers to identify and treat reversible causes of cardiac arrest actively. This process is often remembered by the mnemonic H's and T's, which includes conditions such as hypovolemia, hypoxia, acidosis, hydrogen ion, hypo or hyperkalemia, hypothermia, as well as tension pneumothorax, cardiac tamponade, toxins, and both pulmonary and coronary thrombosis. Additionally, point-of-care ultrasound can serve as a crucial tool during rhythm assessments, helping to identify potential reversible causes, including cardiac tamponade, significant pulmonary embolism, or tension pneumothorax. This technique can assess cardiac motion, right ventricular dilation, or pleural sliding. However, care must be taken to minimize pauses in chest compressions during this assessment. While rapid recognition, prompt high-quality cardiopulmonary resuscitation, and early defibrillation are the cornerstones of resuscitation, identifying the cause of cardiac arrest is essential for effective treatment. This becomes particularly important once the return of spontaneous circulation is achieved. The causes of adult cardiac arrest can be broadly categorized into primary cardiac origins. This category represents the most common clinical finding in adult patients who suffer from cardiac arrest. Coronary artery disease is particularly prevalent among patients experiencing out-of-hospital cardiac arrest. These cases often present with a rhythm of ventricular fibrillation or pulseless ventricular tachycardia. Acute coronary syndrome accounts for approximately 65% of out-of-hospital cardiac arrest cases that exhibit a shockable rhythm. Unfortunately, cardiac arrest can sometimes be the initial clinical sign of coronary artery disease, occurring without any preceding symptoms. In addition to coronary artery disease, there are other cardiac etiologies associated with sudden cardiac death due to ventricular dysrhythmias. These include cardiomyopathies, such as hypertrophic cardiomyopathy, and primary electrical heart diseases like Brugada syndrome, long QT syndrome, short QT syndrome, and catecholaminergic polymorphic ventricular tachycardia. Other contributing factors may involve valvular heart disease, myocarditis, and left ventricular hypertrophy. Cardiac arrest can occur due to various conditions that do not primarily stem from heart-related issues. These non-cardiac causes are quite common, and it is vital to address the underlying problems to maximize the chances of successful resuscitation. In hospital settings, non-cardiac etiologies can be particularly prevalent. One group of non-cardiac causes involves circulatory issues. These issues may arise from problems with blood flow or obstruction. For instance, conditions such as tension pneumothorax, pericardial tamponade, pulmonary embolism, and hypovolemia or hemorrhage play a significant role. Pulmonary embolism, in particular, is recognized as a potentially reversible cause of shock and cardiac arrest. Pulseless electric activity is a common rhythm seen in cardiac arrests related to pulmonary embolism. Metabolic disturbances are also critical factors. Hyperkalemia is the most frequent electrolyte imbalance leading to cardiac arrest. This condition can lead to a progressive widening of the QRS complex, which may deteriorate into ventricular tachycardia, ventricular fibrillation, asystole, or pulseless electrical activity. Other metabolic issues, such as acidosis and low blood sugar, are also recognized as potential causes of cardiac arrest and are noted in the mnemonic for pulseless electrical activity and asystole. Additionally, cardiac arrest can result from drug toxicities, poisoning, or overdose. The characteristics of cardiac arrest due to drug toxicity vary depending on the specific agent involved. Therefore, targeted therapy for the specific drug toxicity is crucial. For example, opioid overdose is highlighted as a significant non-cardiac cause of cardiac arrest. Respiratory failure and severe hypoxia can also lead to secondary cardiac arrest. When patients experience respiratory failure and significant low oxygen levels, they can develop hypotension, which may result in cardiac arrest. Consequently, prioritizing airway management and ventilation is essential for patients in a peri-arrest state, especially those suspected of opioid toxicity, since arrest may occur due to loss of airway patency and lack of breathing. Lastly, trauma is considered a potential cause of cardiac arrest, especially in cases of out-of-hospital cardiac arrest. It is essential to distinguish between primary cardiac arrest and secondary cardiac arrest. In primary cardiac arrest, the blood is initially well oxygenated. In contrast, secondary cardiac arrest often results from hypoxemia. This distinction is important because it influences the appropriate treatment approach. Determining the precise cause of cardiac arrest can be challenging, particularly at the initial presentation. Key information may be unreliable or unavailable. However, gathering historical details from family members, bystanders, and emergency medical services personnel regarding the circumstances of the event can be invaluable. Additionally, understanding the patient's underlying health conditions, risk factors such as coronary artery disease and pulmonary embolism, and current medications can significantly narrow the differential diagnosis. Furthermore, the initial electrocardiographic rhythm serves as a critical piece of information in assessing the situation. Effectively managing patients following return of spontaneous circulation involves diagnosing and treating the underlying causes as part of a comprehensive, goal-directed program for post-cardiac arrest care. For non-shockable rhythms, such as pulseless electrical activity and asystole, successful treatment heavily relies on identifying and addressing these underlying causes. A helpful mnemonic for potential reversible causes of these rhythms includes 6 categories often referred to as the 6 H's and 6 T's. These categories encompass hypovolemia, hypoxia, hydrogen ion, acidosis, hyperkalemia and hypokalemia, hypothermia, hypoglycemia, toxins, cardiac tamponade, tension pneumothorax, thrombosis, either coronary or pulmonary, and trauma. While adult cardiac arrest is frequently a manifestation of acute or chronic heart disease, particularly coronary artery disease, a notable portion arises from treatable non-cardiac conditions. Recognizing these potential etiologies is essential for guiding specific interventions during resuscitation. It also serves to optimize comprehensive post-cardiac arrest care and improve patient outcomes. The clinical picture and the available information play a crucial role in directing the search for these underlying causes. The foundation of our efforts in resuscitation is built upon exceptional chest compressions and timely defibrillation. However, medications also play a supportive and, in certain situations, a critical role in this process. It is crucial to understand when and why we choose specific agents, alongside the evidence that supports their use. This knowledge is vital in managing critically ill patients. The overarching objective remains to restore spontaneous circulation and optimize patient outcomes. This section provides a foundational overview of drug therapy, with a more detailed examination to follow in subsequent chapters. Pharmacological agents are a central component of resuscitation protocols. The primary aim of employing vasopressor therapy after cardiac arrest is to enhance coronary and cerebral perfusion pressures. Typically, chest compressions alone result in low perfusion pressures, and the administration of vasopressors aids in increasing these pressures through their vasoconstrictive properties. Intravenous administration is the preferred method for delivering medications. However, intraosseous access can be utilized if obtaining intravenous access proves difficult or unfeasible. It is essential to minimize interruptions in chest compressions when obtaining vascular access. If available, central venous access may facilitate faster medication delivery compared to peripheral intravenous access, especially when it is followed by a fluid bolus and elevation of the extremities. Nonetheless, during resuscitation, the establishment of central lines above the diaphragm is often not feasible. Epinephrine is a medication that is widely utilized in the treatment of individuals experiencing cardiac arrest. It is typically administered through an intravenous injection with the aim of attempting to restart the heart. As the first-line pharmacologic agent for cardiac arrest situations, epinephrine plays a crucial role in resuscitation protocols. In clinical practice, the common protocol involves delivering a dose of 1 milligram of epinephrine every 3 to 5 minutes to patients in cardiac arrest. For cases involving a non-shockable rhythm, such as asystole or pulseless electrical activity, it is advised that epinephrine be administered as soon as it is feasible. Research indicates that early administration of epinephrine is particularly beneficial for patients facing asystole or pulseless electrical activity, which underscores its emphasis in current treatment algorithms. In instances of cardiac arrest characterized by a shockable rhythm, such as ventricular fibrillation or pulseless ventricular tachycardia, epinephrine should be administered only after initial attempts at defibrillation have proven unsuccessful. Ultimately, epinephrine is a vital component in the emergency treatment of cardiac arrest and is central to enhancing the chances of survival for affected individuals. Epinephrine is a medication that acts as both an alpha and beta receptor agonist. It causes blood vessels to constrict and increases both the rate and strength of heart contractions. The effects on alpha-adrenergic receptors are believed to play a crucial role in enhancing blood flow to the heart muscle and the brain. This action is essential for facilitating the return of spontaneous circulation. The effectiveness of epinephrine has been a topic of debate for many years. Preclinical evidence supports its administration, highlighting improvements in blood flow to the brain and heart during resuscitation efforts. While it is clear that epinephrine enhances the chances of achieving spontaneous circulation, the implications for long-term outcomes, particularly survival with favorable neurological function, remain contentious. Several studies indicate that although epinephrine improves the return of spontaneous circulation, it does not necessarily lead to an increase in the survival rate upon hospital discharge or result in favorable neurological outcomes. For instance, the Paramedic 2 trial, a significant randomized controlled trial, revealed that while epinephrine improved rates of spontaneous circulation, survival to hospital admission, and survival to discharge, it did not enhance the chances of surviving with good neurological function. There are concerns regarding the beta-adrenergic effects of epinephrine, which can be detrimental during or following a cardiac arrest. These effects may contribute to worsened myocardial dysfunction after resuscitation and increase the heart's demand for oxygen. Additionally, experimental research has linked epinephrine with adverse impacts on cerebral microcirculation. Generally, higher doses of epinephrine are not recommended for routine use. Although some trials reported increased rates of spontaneous circulation with high doses of epinephrine, none demonstrated an improvement in survival to discharge or better long-term outcomes when compared to standard doses of the medication. Vasopressin has been explored as either an adjunct therapy or an alternative to epinephrine in the treatment of cardiac arrest. Early experimental and animal studies have suggested that vasopressin might be superior to adrenaline, particularly during prolonged resuscitation efforts. The mechanism of action for vasopressin involves vasoconstriction through V1 receptors. Unlike epinephrine, it does not exert direct effects on the heart muscle. Additionally, vasopressin may dilate cerebral blood vessels more effectively than epinephrine and remains effective even in the presence of acidosis. However, studies comparing the use of vasopressin alone or in combination with epinephrine to the use of epinephrine alone have produced mixed or inconclusive results. A randomized controlled trial conducted in 2001 failed to demonstrate any survival advantage for vasopressin over epinephrine in cases of in-hospital cardiac arrest. Similarly, a 2004 study that compared vasopressin with epinephrine in out-of-hospital cardiac arrest also showed no significant difference in the rates of survival to hospital admission or discharge. Furthermore, a systematic review and meta-analysis revealed no difference in outcomes when trials comparing vasopressin alone or in combination with epinephrine were compared to epinephrine alone. It is important to note that many of these studies were often underpowered, meaning that they included insufficient numbers of participants to draw definitive conclusions. As of 2015, the American Heart Association guidelines no longer recommend the routine use of vasopressin alone in cases of cardiac arrest. Current evidence indicates that vasopressin does not provide any advantage as a substitute for epinephrine during such critical situations. Combination therapy involving vasopressin, steroids, and epinephrine has been thoroughly investigated, especially in the context of in-hospital cardiac arrest. The rationale for incorporating steroids stems from their potential hemodynamic effects, their role in reducing the post-resuscitation systemic inflammatory response, their ability to improve cerebral perfusion, and their effectiveness in potentiating vasoconstrictors. Research has indicated that individuals who do not survive cardiac arrest often display adrenal insufficiency and lower cortisol levels compared to those who survive. Two randomized, double-blind trials conducted by Mintzelopoulos and colleagues in 2009 and 2013 compared a combination therapy of vasopressin and glucocorticoids, specifically methylprednisolone, added to epinephrine during cardiac arrest against a placebo group. The results from these trials revealed a substantial improvement in outcomes, notably a significant increase in survival rates with favorable neurological outcomes in the larger trial conducted in 2013. Despite these findings, the current guidelines in the United States and Europe do not advocate for the routine use of vasopressin and glucocorticoids. This recommendation is primarily due to the insufficient clinical trial data that can confirm the results obtained from these single-center studies. Furthermore, non-randomized studies focusing solely on intra-arrest steroid administration have produced mixed outcomes. A more recent multi-center, randomized, double-blind, placebo-controlled trial, known as the VMIHCA trial, assessed the combination therapy of vasopressin and methylprednisolone against a placebo in cases of in-hospital cardiac arrest. This trial discovered that the combination therapy significantly increased the chances of achieving a return of spontaneous circulation compared to the placebo. However, the study did not provide clear evidence regarding its effects on long-term survival. At the 30 and 90-day marks, there were no observed differences in survival rates or favorable neurological outcomes. Additionally, a systematic review and meta-analysis, which pooled results from 3 trials that evaluated the combination therapy of vasopressin, steroids, and epinephrine, found that this therapy was significantly associated with an increased rate of return of spontaneous circulation. While the ratio of survivors who were discharged favored the combination therapy group, this finding did not reach statistical significance. The analysis also noted benefits in lowering mean arterial pressure and increasing the number of days free from renal and coagulation failures. However, no significant differences were observed in the number of ventilator-free days among the groups. The inconsistencies in findings across various studies, particularly concerning long-term neurological outcomes, leave uncertainty regarding the independent benefits of steroids alone. It remains unclear whether the positive effects are attributed to the specific combination of therapies used or the post-resuscitation care provided. Therefore, further research is essential to clarify the precise role of each component, establish optimal dosages and durations, and identify which patient populations may benefit most from the combination therapy involving vasopressin, steroids, and epinephrine. Amiodarone or lidocaine may be considered for use in patients experiencing ventricular fibrillation or pulseless ventricular tachycardia that does not respond to defibrillation. The primary objective of administering these medications is to prevent the recurrence of these dangerous heart rhythms. Data derived from clinical trials and systematic reviews indicate that both amiodarone and lidocaine have demonstrated improved rates of survival to hospital admission. However, this improvement does not extend to overall survival to hospital discharge or survival with a favorable neurological outcome in cases of out-of-hospital cardiac arrest. Nevertheless, it is noteworthy that both amiodarone and lidocaine significantly improved survival to hospital discharge in a pre-specified subgroup of patients who experienced a cardiac arrest witnessed by bystanders. This suggests that there may be a time-dependent benefit associated with these medications. In a recent retrospective study focusing on in-hospital cardiac arrest involving ventricular tachycardia or ventricular fibrillation, lidocaine was shown to be associated with significantly higher odds of return of spontaneous circulation, 24-hour survival, survival to discharge, and a favorable neurological outcome when compared to amiodarone. Other antiarrhythmic agents such as beryllium, sotalol, and procainamide present limitations or have unclear benefits during cardiac arrest situations. Moreover, the efficacy of various antiarrhythmic drugs when used in combination is not systematically addressed in the existing literature. Prophylactic administration of lidocaine following successful defibrillation and return of spontaneous circulation has been associated with a decrease in the recurrence of ventricular fibrillation or pulseless ventricular tachycardia, but this approach did not correlate with an improvement in survival to hospital discharge. In the context of cardiac arrest, the routine administration of calcium is generally not advised. However, there are specific circumstances where it may be considered, such as in cases of cardiac arrest caused by hyperkalemia. In these situations, intravenous administration of calcium chloride or gluconate can be beneficial, as it helps stabilize the myocardial cell membrane. It is important to note that a recent randomized trial, which compared the use of calcium to saline in out-of-hospital cardiac arrest without a clear indication for calcium, was halted early due to concerns of futility and potential harm. Similarly, routine use of sodium bicarbonate is not recommended for patients undergoing cardiac arrest. However, it may be considered in special situations, including instances of hyperkalemia, tricyclic antidepressant overdose, or salicylate toxicity. During cardiac arrest, acidosis develops due to poor perfusion and inadequate ventilation. Despite this, studies have failed to demonstrate that sodium bicarbonate improves the rates of return of spontaneous circulation or overall survival. In fact, some studies have reported that the pre-hospital use of sodium bicarbonate is associated with worse neurological outcomes, although the exact mechanism behind this observation remains unclear. Magnesium administration during cardiac arrest has not shown any benefit in clinical outcomes when used as a routine practice. Therefore, magnesium should only be given in cases of torsade de pointes. The use of thrombolytics during cardiac arrest is not recommended as a standard approach. However, thrombolytic therapy can be considered for patients with cardiac arrest when pulmonary embolism is suspected as the cause. In instances where pulmonary embolism is confirmed, thrombolysis becomes a reasonable emergency treatment option. Although evidence collected from observational studies is mixed and can be biased, the risk of death from cardiac arrest due to confirmed pulmonary embolism is deemed to outweigh the bleeding risks associated with thrombolysis. In cases of specific toxic exposures, the administration of certain antidotes may be necessary. For opioid overdoses, immediate treatment with naloxone is essential. For digoxin overdoses, antidigoxin Fab fragments are both safe and effective for treating severe arrhythmias, although data regarding their efficacy specifically during cardiac arrest is limited. Sodium bicarbonate might be an option for managing overdoses caused by sodium channel blockers, such as tricyclic antidepressants. Pharmacologic therapy plays a crucial role during adult cardiac arrest as an adjunct to high-quality cardiopulmonary resuscitation and defibrillation. Epinephrine is the primary vasopressor, focusing on improving perfusion pressures and achieving return of spontaneous circulation. The impact of epinephrine on neurological outcomes remains a subject of debate. While other agents like vasopressin and certain steroid combinations display potential in specific situations, such as in-hospital cardiac arrest or for short-term outcomes like ROSC, the evidence is inconsistent. As a result, these agents do not yet have enough support for routine use as alternatives or complements to standard epinephrine outside of clinical trials or very specific scenarios. Antiarrhythmic medications are considered for patients experiencing refractory shockable rhythms. Other specific medications, including calcium, bicarbonate, magnesium, thrombolytics, and antidotes, are reserved for addressing identified underlying causes or specific arrhythmias. The overarching goal is to support effective circulation and address reversible causes, thereby facilitating the return of spontaneous circulation while remembering that the priority remains on high-quality compressions and defibrillation. The core principles of basic life support and advanced life support remain essential. However, certain causes of cardiac arrest present unique challenges that necessitate tailored interventions. It is crucial to understand these special circumstances in order to optimize patient outcomes. It is important to remember that the absence of signs of circulation defines cardiac arrest. The overall approach to treatment continues to follow the chain of survival, which emphasizes rapid recognition, high-quality cardiopulmonary resuscitation, early defibrillation, and advanced care. When cardiac arrest is caused by anaphylaxis, the priority is to apply standard resuscitative measures while immediately administering epinephrine. Evidence regarding the treatment of cardiac arrest induced by anaphylaxis is limited to case reports and inferences from non-fatal cases, as well as pathophysiological studies and consensus opinions. Urgent support for airway, breathing, and circulation is essential. The cornerstone of management involves standard basic life support and advanced life support protocols, which include airway management and the early administration of epinephrine. There is no proven benefit from the use of antihistamines, inhaled beta agonists, or intravenous corticosteroids during a cardiac arrest specifically caused by anaphylaxis. Cardiac arrest occurs in approximately 1 to 8% of cardiac surgery cases. The causes can include tachyarrhythmias, such as ventricular tachycardia or ventricular fibrillation, bradyarrhythmias, like heart block or asystole, as well as obstructive causes such as cardiac tamponade or pneumothorax. Technical issues, including graft occlusion or bleeding, can also lead to cardiac arrest. These events often occur in highly monitored settings such as intensive care units, where trained staff are present. The immediate goal in such scenarios is to restore perfusion through cardiopulmonary resuscitation, to initiate advanced life support, and to quickly identify and correct the underlying cause of the arrest. External chest compressions should be performed if emergency resternotomy is not immediately available. In cases where a trained provider witnesses the arrest of a patient who has recently undergone cardiac surgery, immediate defibrillation for ventricular fibrillation or ventricular tachycardia should be performed. If defibrillation is not successful within 1 minute, cardiopulmonary resuscitation should then be initiated. Mechanical circulatory support has shown effectiveness in improving outcomes for post-cardiac surgery patients who are unresponsive to standard resuscitation procedures. Drowning, While not extensively detailed in the provided excerpts beyond being listed as a cause of out-of-hospital cardiac arrest, is mentioned in the context of the 2010 American Heart Association guidelines. Cardiac arrest due to asphyxia, such as that caused by drowning, raises concerns since prolonged periods without ventilation may be less effective than conventional cardiopulmonary resuscitation. Cardiac arrest during pregnancy is a critical event that can occur, necessitating immediate medical attention and intervention. The current literature primarily consists of observational studies, which means that treatment decisions are often based on the physiological changes of pregnancy and insights drawn from cases without cardiac arrest. It is vital to implement high-quality resuscitative and therapeutic interventions that focus on the most likely causes of the cardiac arrest. The principles of basic life support and advanced life support are applicable in these scenarios. Perimotum cesarean delivery, also known as resuscitative hysterotomy, can significantly improve maternal outcomes when performed at or beyond 20 weeks of gestation, especially if resuscitation does not quickly achieve return of spontaneous circulation. Recent findings suggest that shorter intervals between the cardiac arrest and the delivery may enhance both maternal and neonatal outcomes. However, making the clinical decision about the timing of perimotum cesarean delivery is complex and takes into account various factors such as the healthcare provider's training, the patient's condition, and available medical resources. There are case reports and series that document successful maternal survival in patients experiencing cardiac arrest who were treated with extracorporeal membrane oxygenation. Nevertheless, the treatment of cardiac arrest occurring in late pregnancy represents a significant scientific gap in current knowledge and research. Pulmonary embolism is a potential cause of cardiac arrest, frequently presenting with pulseless electrical activity. Identifying pulmonary embolism as the underlying cause of the cardiac arrest can be particularly challenging. Point-of-care ultrasound is a valuable tool in this context, as it can help in recognizing pulmonary embolism by examining right ventricular dilation. However, it is essential to minimize pauses in chest compressions during this assessment. The inferior vena cava assessment may also indicate the presence of obstructive shock, which is critical to note. Currently, there are no randomized trials investigating treatment options for cardiac arrest that is secondary to confirmed pulmonary embolism. Observational studies regarding fibrinolytic therapy for suspected pulmonary embolism have been criticized for substantial bias and present mixed outcomes. Despite this, the consensus is that the risk of death from cardiac arrest outweighs the potential risk of bleeding resulting from thrombolysis. Surgical embolectomy and percutaneous mechanical thrombectomy have produced varying rates of return of spontaneous circulation and survival in case series, and the decision between thrombolysis or mechanical/surgical thrombectomy relies on timing and the expertise available at the medical facility. Certain toxic exposures and electrolyte imbalances can lead to cardiac arrest, which may require specific antidotes or therapies. In cases of hyperkalemia, the administration of calcium and sodium bicarbonate may be considered. However, routine calcium administration is not recommended for general cardiac arrest situations. Likewise, the routine use of sodium bicarbonate is generally not advised for cardiac arrest, except in special circumstances like hyperkalemia. For sodium channel blocker overdose, such as that caused by tricyclic antidepressants, sodium bicarbonate may be deemed appropriate. In instances of digoxin overdose, while there is a lack of data regarding the use of antidigoxin Fab fragments specifically during cardiac arrest, evidence from trials and case series supports their safety and effectiveness for treating serious arrhythmias resulting from digitalis overdose in other clinical settings. Similarly, patients experiencing cardiac arrest due to carbon monoxide poisoning face poor survival rates following hospital discharge, irrespective of post-return of spontaneous circulation treatment. Clinical trials assessing hyperbaric oxygen therapy for preventing neurological injury have excluded cardiac arrest patients, leading to conflicting outcomes. Other toxins can also lead to cardiac arrest, although they are not explicitly discussed in the provided excerpts. Managing cardiac arrest resulting from various toxins is recognized as a special circumstance in resuscitation guidelines. In all these specific situations, Maintaining high-quality cardiopulmonary resuscitation and the timely activation of emergency medical services are fundamental. Advanced life support interventions build upon these essential practices, with modifications or additional actions based on the suspected or confirmed etiology of the cardiac arrest. Furthermore, comprehensive post-cardiac arrest care is crucial for these patients once return of spontaneous circulation is achieved, emphasizing the need to address the underlying cause and manage the multi-system effects resulting from the cardiac arrest and subsequent resuscitation. The literature acknowledges that while standard algorithms provide a framework, further research is needed to optimize care in many of these specific circumstances. Post-cardiac arrest care is recognized as a critical component of the chain of survival. Achieving a return of spontaneous circulation marks just the beginning of managing a cardiac arrest survivor. This phase requires comprehensive multi-system care to address the various needs of the patient. The primary goals during this period include the rapid diagnosis and treatment of the disorders that cause the cardiac arrest. Additionally, it is essential to manage the complications that arise from prolonged global ischemia. A comprehensive and goal-directed program of post-cardiac arrest care is necessary to optimize both survival and neurological recovery. The necessity for post-cardiac arrest care derives from the post-cardiac arrest syndrome. This syndrome results from systemic ischemia, which is precipitated by the lack of perfusion during the arrest and the subsequent reperfusion response during cardiopulmonary resuscitation, as well as the return of spontaneous circulation. The severity of this syndrome varies depending on the duration and cause of the arrest. Post-cardiac arrest syndrome comprises 4 main components. These include hypoxic brain injury, myocardial dysfunction, the systemic ischemia reperfusion response, and the underlying pathology that caused the arrest in the first place. This lecture just provides a detailed overview of crucial elements in the care of patients who have experienced cardiac arrest. A comprehensive and structured multidisciplinary system of care must be consistently implemented for the treatment of post-cardiac arrest patients. Adopting this systematic approach may enhance clinical outcomes, much like regionalized care strategies utilized for other medical emergencies. Structured treatment protocols, defined in terms of care bundles and guided by specific treatment goals, can prove beneficial in improving patient care. Temperature management has been a primary focus for many years. Hypothermic targeted temperature management has demonstrated efficacy in improving both survival rates and functional outcomes among comatose survivors of cardiac arrest. It is recommended that all adults who do not respond to commands after the return of spontaneous circulation receive a treatment strategy that includes a deliberate plan for temperature control, irrespective of where the arrest occurred or the initial heart rhythm presented. Maintaining a stable body temperature between 32 degrees Celsius and 37.5 degrees Celsius is advised during the post-arrest temperature management period. However, there is currently insufficient evidence to endorse a specific therapeutic temperature for various subgroups of patients. Recent large randomized controlled trials comparing a target temperature of 33 degrees Celsius to normothermia, which includes fever treatment, or to moderate hypothermia set at 31 degrees Celsius versus mild hypothermia set at 34 degrees Celsius in predominantly heart-related cardiac arrest patients with shockable rhythms, did not reveal any significant differences in either functional outcomes or mortality rates. It is essential to note that these findings may not be applicable to the general post-arrest population, where non-shockable rhythms and non-cardiac causes are more prevalent. Furthermore, post-hypothermia fever has been linked to increased mortality rates, emphasizing the need for preventing hyperthermia. Coronary artery disease frequently serves as a common cause of out-of-hospital cardiac arrest, especially in cases involving ventricular fibrillation or pulseless ventricular tachycardia. A 12-lead electrocardiogram should be obtained as soon as possible after the return of spontaneous circulation to assess for ST segment elevation. Emergency coronary angiography should be performed for all cardiac arrest patients suspected of having a cardiac cause of arrest accompanied by ST segment elevation on their electrocardiogram. In cases of selected adult patients without ST segment elevation but with a high suspicion of significant coronary artery disease, emergent coronary angiography is justified. This is particularly true if the patient experiences shock, electrical instability, signs of ongoing myocardial damage, or continuous ischemia. Moreover, coronary angiography should be considered for all post-cardiac arrest patients when clinically warranted, regardless of the patient's mental status. Evidence suggests that early coronary angiography and intervention are associated with improved short-term and long-term survival rates following out-of-hospital cardiac arrest. Neurological management is crucial following a hypoxic ischemic brain injury, which is a significant cause of death and disability after cardiac arrest. The post-arrest brain injury encompasses both primary injuries resulting from ischemia and reperfusion, as well as secondary injuries caused by factors such as hypoxia, edema, elevated intracranial pressure, and seizures. In patients who remain comatose after cardiac arrest, neuroprognostication must incorporate a multimodal approach rather than relying on a singular finding. It is essential to delay prognostication until any potential confounding factors, such as the effects of medications or transiently poor examination findings, have subsided. Regular and transparent multidisciplinary discussions regarding the anticipated time course and uncertainties surrounding neuroprognostication should be conducted with the patient's surrogates. Seizures can manifest after a cardiac arrest. While it may be appropriate to consider anticonvulsant regimens for seizures that arise from various etiologies, it is important to note that seizure prophylaxis is typically not recommended for adult survivors of cardiac arrest. In terms of pulmonary management, overseeing respiratory parameters plays a vital role in the initial stabilization process following the return of spontaneous circulation. This process includes initiating mechanical ventilation with a suitable breath rate, such as 10 breaths per minute. It is advisable to target an oxygen saturation level between 92 and 98%, while also maintaining an arterial partial pressure of carbon dioxide within the range of 35 to 45 millimeters of mercury. To prevent hypoxia immediately after cardiac arrest, employing the highest oxygen concentration available is considered appropriate until reliable measurements can be obtained. Although the impact of varying inspired oxygen concentrations during cardiopulmonary resuscitation is not extensively researched, there remains a significant interest in understanding how oxygen and carbon dioxide levels influence brain injury after an arrest. Hyperoxia is believed to be potentially harmful, and further research is needed to determine the effects of hypercarbia and hypocarbia on patient outcomes. Lung protective ventilation is now considered standard care for patients at risk of developing acute respiratory distress syndrome, which frequently occurs after cardiac arrest. Important aspects of this approach include targeting low tidal volumes of 4 to 8 milliliters per kilogram of ideal body weight, titrating positive inexpiratory pressure, and consistently monitoring plateau and driving pressures. Additionally, elevating the head of the bed to a minimum angle of 30 degrees is recommended to enhance patient care. Hemodynamic parameters should be managed, particularly focusing on systolic blood pressure levels above 90 millimeters of mercury and mean arterial pressure levels above 65 millimeters of mercury. A low mean arterial pressure is associated with worse clinical outcomes. Observational studies indicate that higher mean arterial pressures are linked to better neurological outcomes. However, clinical trials targeting different mean arterial pressure ranges, such as those between 65 to 75 and 80 to 100 millimeters of mercury, demonstrated feasibility and safety, but were not sufficiently powered to assess their impact on survival or neurological outcomes. It is crucial to remain vigilant for infections and provide appropriate treatment. Despite this, the routine use of prophylactic antibiotics in patients who have recently suffered from cardiac arrest remains uncertain in terms of benefits. Various trials have reported mixed results regarding improvements in survival rates and neurological outcomes, although one trial indicated a reduction in early pneumonia cases. Management of glucose levels should generally adhere to the protocols for critically ill individuals. The aim should be to maintain blood glucose levels between 150 and 180 milligrams per deciliter, utilizing insulin when necessary. The advantages of targeting specific glucose levels continue to be uncertain. Routine administration of calcium for patients experiencing cardiac arrest is not recommended, except in particular situations such as hyperkalemia. Similarly, the routine use of sodium bicarbonate is generally not advised. However, it may be considered in certain cases, including hyperkalemia, tricyclic antidepressant overdose, or salicylate toxicity. The effectiveness of agents designed to mitigate neurological injury remains unclear. The routine administration of steroids to patients in shock following return of spontaneous circulation is also of uncertain value. Nevertheless, a combination of vasopressin, epinephrine, and corticosteroids administered during and after an in-hospital cardiac arrest may significantly enhance the likelihood of achieving return of spontaneous circulation and potentially improve outcomes, such as reducing the days free from renal and coagulation failure. However, the long-term survival effects of this combination treatment are still uncertain. Mechanical circulatory support and extracorporeal cardiopulmonary resuscitation are emerging as effective options for improving outcomes in post-cardiac surgery patients whose cardiac arrest is resistant to standard resuscitation methods. The application of mechanical circulatory support, including extracorporeal membrane oxygenation, is expanding for patients after return of spontaneous circulation in order to maintain organ perfusion. There is a lack of robust randomized trials available to guide patient and device selection during the post-return of spontaneous circulation phase. Trials specifically evaluating extracorporeal cardiopulmonary resuscitation for refractory cardiac arrest, in which return of spontaneous circulation is not achieved through standard efforts, have yielded mixed results and presented various limitations. Recovery and survivorship is the newest link added to the chain of survival for both out-of-hospital cardiac arrest and in-hospital cardiac arrest. It highlights the extensive journey of recovery and survivorship, which continues long after a patient is discharged from the hospital. Survivors often experience a wide range of issues that can be physical, neurological, cognitive, emotional, or social in nature. Comprehensive and multidisciplinary discharge planning is recommended. This planning should include medical and rehabilitative treatment recommendations, as well as expectations for returning to activity or work. Survivorship plans must be provided to patients and their caregivers to help optimize transitions of care and address recovery expectations. Additionally, debriefings and emotional support for lay rescuers, emergency medical service providers, and hospital staff following a cardiac arrest event may prove to be beneficial. Post-cardiac arrest care is an essential phase of adult cardiac arrest resuscitation, beginning immediately after the restoration of spontaneous circulation. This phase focuses on managing the systemic effects of ischemia-reperfusion injury, also known as post-cardiac arrest syndrome. It involves identifying and treating the underlying cause of the cardiac arrest while also optimizing organ function, particularly neurological recovery. Key components of this care include temperature control, targeted cardiovascular interventions like emergent angiography, meticulous neurological management, and comprehensive critical care. The latest emphasis in this field is on the long-term journey of recovery and survivorship. This recognizes the physical, cognitive, and emotional needs of survivors and their families. While significant advancements have been made and guidance is available, there remain areas of uncertainty. There is an ongoing need for high-quality research to refine management strategies and enhance outcomes for this complex patient population. Despite extensive research, considerable uncertainty remains regarding the optimal care strategies during and after cardiac arrest. The management of patients who have survived a cardiac arrest is often complicated by the absence of high-quality clinical studies. This gap in research leads to limited high-certainty evidence and results in variability in treatment approaches. Many recommendations for post-cardiac arrest care are drawn from studies involving other critical care populations. The challenges in treating cardiac arrest patients are numerous. They include the wide range of causes and presentations of cardiac arrest, potential biases inherent in observational studies, and the necessity for appropriate measures to assess outcomes, particularly concerning long-term neurological function. Moving forward, it is essential for future research to focus on conducting high-quality trials. Such studies are crucial for refining existing guidelines and addressing existing knowledge gaps. Cardiac arrest is a common, yet often fatal event. While immediate resuscitation efforts, such as cardiopulmonary resuscitation, defibrillation, and administration of epinephrine are critical. The outcomes for patients are significantly influenced by the care provided after return of spontaneous circulation. This post-resuscitation care includes targeted interventions such as emergent angiography and temperature control, in addition to comprehensive critical care management and an effective overall system of care. Enhancing the rates of survival with favorable neurological function, along with addressing the long-term needs of cardiac arrest survivors, represents ongoing challenges that continue to drive current research efforts. Here's a summary of key points about resuscitating adults with cardiac arrest. Adult cardiac arrest is a life-threatening event marked by three main characteristics: loss of consciousness, no breathing, and no circulation, which is known as pulselessness. It's a significant public health concern due to its high mortality rates worldwide. Unfortunately, cardiac arrest outcomes are poor, with low survival rates and many patients not surviving to leave the hospital. For example, 2020 data from the U.S. shows only 9% of out-of-hospital cardiac arrests and 23% of in-hospital cardiac arrests resulted in hospital discharge. A key goal of resuscitation efforts is to save lives with a good neurological outcome, as brain damage after cardiac arrest is a major cause of death and disability. There are two main types of cardiac arrest causes: primary cardiac causes and non-cardiac causes. Primary cardiac causes are the most common and often relate to coronary artery disease, especially ventricular fibrillation or pulseless ventricular tachycardia and out-of-hospital cardiac arrests. Non-cardiac causes include circulatory issues, metabolic problems, toxic exposure, and respiratory failure, which are more common in in-hospital cardiac arrests. Identifying and treating the underlying cause is crucial for improving outcomes. The chain of survival guides cardiac arrest management, outlining a series of critical steps for effective intervention. There are two distinct chains for out-of-hospital and in-hospital cardiac arrests. For out-of-hospital cardiac arrests, the chain includes activating emergency responders, starting high-quality CPR, defibrillation, advanced resuscitation efforts, post-cardiac arrest care, and recovery. In contrast, the in-hospital chain focuses on early recognition and prevention, followed by activating emergency responders, starting high-quality CPR, defibrillation, post-cardiac arrest care, and recovery. Basic life support forms the foundation of resuscitation efforts, including quickly recognizing cardiac arrest and activating the emergency response system. High-quality CPR is essential for restoring blood flow to the heart and brain. Key metrics for effective CPR include a compression rate of 100 to 120 per minute, a depth of 5 to 6 centimeters, a compression fraction of at least 80%, full chest recoil between compressions, and minimal interruptions. Early defibrillation is critical for survival in ventricular fibrillation or pulseless ventricular tachycardia, especially when done early in the resuscitation process. Automated external defibrillators make it easy for lay responders to use during cardiac emergencies. Advanced life support builds on basic life support, involving more complex interventions like medication, advanced airway management, and addressing reversible causes of cardiac arrest. Identifying and treating reversible causes is vital during resuscitation. This assessment often uses the H's and T's mnemonic, which includes hypovolemia, hypoxia, hydrogen ion imbalances, hypo, or hyperkalemia, hypothermia, tension pneumothorax, cardiac tamponade, toxins, thrombosis related to pulmonary or coronary arteries, and trauma. Point-of-care ultrasound can help identify some of these causes. Medication plays a supporting role during cardiac arrest resuscitation. Epinephrine is the recommended first-line vasopressor, and it should be given as soon as possible for non-shockable rhythms and after unsuccessful defibrillation attempts for shockable rhythms. Epinephrine primarily works by stimulating alpha receptors, increasing blood flow to the heart and brain. While epinephrine improves the chances of return of spontaneous circulation, its effect on achieving a good neurological outcome is still debated. Vasopressin has been explored, but it's not routinely recommended as a standalone treatment because it doesn't offer any advantage over epinephrine. Antiarrhythmic medications like amiodarone and lidocaine may be considered for managing ventricular fibrillation or pulseless ventricular tachycardia that doesn't respond to defibrillation. These medications have shown potential benefits for survival to hospital admission and may improve chances of survival to discharge in out-of-hospital cardiac arrests witnessed by bystanders. Certain other medications have specific indications. Calcium should not be used routinely, but only for hyperkalemia. Sodium bicarbonate and magnesium should not be used routinely either. They may be considered for hyperkalemia, tricyclic antidepressant overdose, salicylate toxicity, or torsades de pointes, respectively. Thrombolytic therapy is not routinely recommended, but may be considered for cardiac arrest suspected or confirmed to be due to pulmonary embolism. Post-cardiac arrest care is crucial after the return of spontaneous circulation. This care addresses post-cardiac arrest syndrome, which includes hypoxic brain injury, myocardial dysfunction, and systemic ischemia-reperfusion, along with any underlying conditions that cause the cardiac arrest. Management during this phase requires a comprehensive, multi-system approach in an intensive care setting. Targeted temperature management is recommended for comatose survivors, aiming for a temperature range of 32 to 37.5 degrees Celsius. Preventing hypothermia during this phase is essential for optimizing neurological outcomes. Emergency coronary angiography is recommended when there's a suspected cardiac cause of cardiac arrest, especially in cases with ST segment elevation or high suspicion of coronary artery disease. Neurological concerns arise from the risk of hypoxic ischemic brain injury, so neuroprognostication should be conducted in a multimodal manner with delays to ensure accurate assessments. Seizure prophylaxis is generally not recommended in this context. Pulmonary management involves mechanical ventilation, targeting oxygen saturation levels of 92 to 98% and carbon dioxide levels of 35 to 45 millimeters of mercury using lung protective ventilation practices. Overall, general critical care for these patients includes managing hemodynamics, aiming for a mean arterial pressure of over 65 millimeters of mercury and a systolic blood pressure of over 90 millimeters of mercury. Routine prophylactic antibiotics and proper glucose management should follow standard critical care practices. Recovery represents the newest link in the chain of care for cardiac arrest survivors. It acknowledges the long-term physical, cognitive, emotional, and social needs of survivors following hospital discharge. Comprehensive discharge planning is strongly recommended to support these needs. Certain specific scenarios post-cardiac arrest may require tailored interventions in addition to standard basic and advanced life support protocols. Examples include anaphylactic reactions, where immediate administration of epinephrine is necessary, rapid identification and correction of causes following post-cardiac surgery, immediate defibrillation in cases of witnessed ventricular fibrillation or ventricular tachycardia, as well as consideration for drowning, pregnancy, where perimodem cesarean section may be indicated if there is no rapid return of spontaneous circulation after 20 weeks of gestation, prevention of complications. Following pulmonary embolism with possible thrombolysis, and management of toxic exposures with specific antidotes as indicated. This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.